Hi, this is the ECG and this is my take on the ECG. The first thing which you notice in the visual inspection is that you got ST elevations in V2, you got ST elevations in V3, you got ST elevations in V4, you got ST depressions in 2, you got ST depressions in 3, you got ST depressions in AVF. Okay, right. So you have inferior ST depressions, anterior, or even, the septal. V1 is the septal lead, right? I can't see any, it's more or less it's elevated. Though it's not clear, but we can say that it's elevated. There's septal elevations in V1. So you have ST elevations in all the anterior leads and ST depressions in all the inferior leads. Those may be reciprocal changes, although there are some rules in reciprocity, right? One of the rules was that anterior doesn't reciprocate to any, but anybody can review those rules and go through them again. The other thing which you notice is that we have an extra beat here, right? This is a ventricular extrasystole. It might be, in the baseline, or it might be due to the tension that's caused by the infarction that's going on. There's an infarction that's going on, which nobody can miss. There is an anterior myocardial infarction going on in this ECG. Okay, let us carry on to, try to spot many other ECG findings. What about the axis? The axis, observe 1 and 2 whenever the axis is discussed. So you have left axis deviation, okay? This might be an indicative to left anterior vesicle block, right? And this can happen in myocardial infarctions, right? Anything else? The rate, you got 1, 2, 2.5 almost, large squares between any two successive beats. That means that the rate is around 100. It's okay. What else we can observe? We have ST depressions in V6. We have ST depressions in V5. Okay? In all the lateral leads, you have ST depressions. In all the inferior leads, you have ST elevations. In AVR, we have an ST elevation. So somebody might kind of think about that there is a global subendocardial ischemia, and this global subendocardial ischemia is due to the quality of the supply, not just the quantity of the supply. Okay, if there's an occlusion, the issue, is going to be in the quantity of the supply. But if there's, any other disease, any other issue in the blood, sepsis, something like that, okay, insufficiency is ischemia, right? Global subendocardial ischemia points you to think about that there's a problem in the quality, okay? But here, we can notice some other thing. We have depressions, lead 3, okay? Elevations, or the things are going to develop as elevations in 1, okay? This is a pattern, okay? And between 1 and 3, you got AVL. AVL is okay. This is a pattern that's called South African flag, right? And it indicates an occlusion in D1, okay? All in all, when you say that, you got anterior infarction going on. Observe those T-wave inversions, okay? And when you also note that you got depressions in all the lateral leads, reciprocal changes, and in all the inferior leads, reciprocal changes, okay? Uh, in this case, you have to think about that the occlusion is in the proximal left axis, proximal LAD. The left coronary artery does have two branches, the left circumflex artery and the left descending artery. So the proximal point, or some proximal point in the left coronary artery, particularly in the left descending, in the left anterior descending branch, is occluded in this ECG. This is an acute case, right? And if you wait further, you'll see that the changes intensify, okay? Especially this change would intensify in V2. What else do we have? Observe V1. Normally, V1 should not be upward because it's far away from the left ventricle. But now it's upward. This is a sign actually to many things, but one of those things is right bundle branch block, especially that if you zoom, the tip of the QRS complex is forming something like letter M, right? With one side being greater than the other side. Okay? When you have right bundle branch block, and we also discovered before that there's a sign of left anterior fascicle block. This is a bifascicular block. This kind of the block, the bifascicular block, maybe baseline. We don't know about that. We have to compare with all the ECGs, or maybe developing right now a response to the MI, in response to the anterior MI, especially that the MI is anterior, right? I apologize about, I mentioned that the rate is around 100. It's not about 100. You got two larger squares and half, so this makes the rate about 120 or 125 beats per minute. This is a tachycardic rate. There's a tension going on. This is a response to the myocardial infarction taking place in this ECG. Thank you.